Good evening, everyone. My name is Theresa. I am an SLP and I'm doing the presentation tonight over a little bit of feeding therapy. I was just talking to Allison about this, how we take entire courses on this. So I'm going to try to kind of glean over kind of the important areas such as feeding development, some anatomy, and of course some intervention strategies that you can take home with you and start implementing in your practice. If you get questions or if you want me to delve into anything more specific, please feel free to put it in the chat. We'll address those as we do the presentation. And then, of course, my email will be at the end of on the very last slide so that y'all are able to contact me about any other specific questions about certain patients. Okay. Like I said, my name is Theresa. A little bit about me. I'm located in Fort Worth, Texas. I'm employed at Cook Children's Hospital, which is the main hospital in Fort Worth. And then I kind of specialize in multiple areas. I kind of love everything about my scope of practice. So I do, of course, feeding therapy anywhere from infants up to 21. I do augmentative communication. I see kids with apraxia. I also work closely with children who have facial palsy, such as working on facial reanimation. And then, of course, one of my nearest and dearest things to my heart are any children who have complex needs. Some things that we're going to be learning about, kind of my targets for today, is explaining what typical feeding development is and identifying those needs for intervention. Making sure you leave today with some intervention strategies to support this population, and then defining what a pediatric feeding disorder is. So Allison, here's time for our poll. I would love to know what the audience's experience is with feeding therapy. So go ahead and take just a few moments to complete that poll.
All right, so it looks like 49% of our audience is saying little to no experience, 25% is at 1 to 4, 17% is at 5+, and 9% is saying this is my area of expertise.
Okay, awesome. Great to see that we've got a little bit of variety, but that the majority of our audience is this kind of new area, new territory for them. So I love that we're kind of broadening this scope and seeing so many people are interested in this. I looked up the more recent incidence rate of children with feeding problems. The incidence rate is 10 to 25% of the pediatric population. And of course, those numbers adjust 40 to 70% of premature infants, and then 70 to 80% of children with disabilities. So definitely a need for lots of people interested in this area. So I always like to start off when I'm looking at anything to, sorry guys, going backwards, refresh ourselves on some anatomy. I could go over what all of these muscles do and how they all work as a family for lots of things, but the main ones I think that are important for everyone to know are in charge of our muscular sling, which is the buccinator. I've heard it pronounced multiple ways, and those are over here in your cheeks. Those are going to help with bolus management, helping that food stay where it needs to stay so that children are able to chew it. Also helps with straw drinking, bottles, kind of just, it's a big factor with eating. And then we have the orbicularis oris, which is the one that goes around your lips here, that kind of wraps in a circle. Those I find are pretty obvious why we need those. It helps the food stay in the mouth. It helps wrap around the bottle. It helps us wrap around straws, stabilizing for open cup drinking. And then the other main muscle that is not shown in this diagram is the superior pharyngeal constrictor. That's going to be more towards the back in your throat. And that is when it works with the buccinator and the orbicularis oris, it provides some positive pressure to kind of help that food start to go down and go into that swallowing phase. So I find those are really, really important to remember when you're working with kids with feeding challenges. Other ones, of course, are going to be your masseter, which is over here on your jaw. That one is great for chewing. It helps elevate that mandible for jaw closure. So we kind of think that's what we need for chewing. That's what we need to just when we're in the resting posture to keep our mouth closed. That's so important. And then, of course, the tongue muscles. There are 4 major ones, and they all serve a different purpose. I could go very deep into the different ways that these muscles go into, but we've got the genioglossus, that's protrude and depression, hyoglossus, depression and retraction, styloglossus, retraction and elevation, and palatoglossus, elevation and posterior movement. Because the tongue is a very eloquent muscle. That's how I always tell to the families I work with. And so it has a lot of needs that it needs to do. And so multiple muscles in there. And then I always like to show a diagram from the lateral view. I see a lot of this when I'm doing swallow studies, so I find that it's helpful. And I do show this to the families that I work with to kind of give them an idea of what the whole phase looks like. So when we eat, it's not just, oh, we chew it and then we swallow it. There's so many more smaller pieces to that. So I try to explain it to the families as best as I can by showing them that it enters the mouth, the lips help kind of keep that food in the mouth or close on that spoon. And then it enters the mouth, and then the tongue usually needs to do something. It needs to move the food to the side, or it needs to start providing a suckle. And then from there, it starts to move back that anterior posterior movement, and that base of that tongue and the posterior pharyngeal wall right here, those 2 areas are going to help push together and then send that food down for to go down into the esophagus. And then the velum, which is up at the top towards the nose, that needs to close to make sure nothing goes up through the nose. So all of that has to happen in such a short amount of time. So I like showing this to families to show that these kids are trying to do so much in such a small amount of space in such a short amount of time, just to give them just another perspective of what we're working on. And then, of course, after we move through the oral phase, we're going to move into the pharyngeal phase, which is where it goes more down into the esophagus. Right here along the spine, that's going to be your esophagus. And then towards the front, that's the airway and the vocal cords. Those are the areas ideally we don't want anything going towards. And I will dive more into a little bit about swallow studies and kind of what we look for there too, just so then y'all are familiar with the terminologies. In the event you have to read an MBSS report or those swallow study reports. All right, now that I've kind of gleaned over that, let's glean over evaluations. The first thing, of course, you're going to do that chart review. The 3 main things I'm looking for when I chart review for my patients is, are there specialists involved, and what specialists are already involved in this child's life? That just gives me insight as to who already has given this family answers. So that might be anything like an ENT regarding structural things in their airway. That might be gastroenterology regarding reflux management. That might be a dietitian through their primary care doctor that has looked at their nutrition as a whole and their weight gain. And then I'm going to look for any MBSS or swallow study reports to make sure that has been addressed if it was needed. And then I would look at their growth curve if I'm lucky enough to have a copy of their growth chart attached with their order. And then once they're in my clinic, we do, of course, a case history where it's not just a medical review, medical history, them telling me their concerns. I'm trying to get an idea of the family's goals, what their biggest concerns are, and what they're seeing at home. We ask all of the families that come to our sessions to bring food with them and the child's preferred cup or bottle, and then also to bring something that's challenging for the child so that we've got kind of an array of things to look at. And based on what that family brings, that gives me more idea of what kind of questions I want to ask them. along the lines of like, how are you presenting it? Tell me what they do when they eat those things, what they do when they drink. So then I can already start thinking of what I'm going to look for during my bedside evaluation. And that is more specifically where I'm with that child, actually watching them eat and drink. After the case history, depending on the age of the child, of course, we're going to try to do an oral mech exam. And I say try because if you work with 2-year-olds or 3-year-olds, you kind of remember that experience of they're on their own agenda. If they want to do it, they'll do it. If they don't, they don't. A couple of things that I do to kind of have the oral mech exam happen is I will have a book. I've got a couple books in my room that kind of go through an oral mech exam, like open your mouth wide, blow a kiss, catch a bubble in your cheeks. And that just makes it more fun as opposed to having a stranger tell them, here's what I want you to do, or hey, let this strange woman stick their finger in your mouth. So sometimes I warm up with that just to be very child-led. And what I'm looking for during this mech exam is structure. So does something look different, such as enlarged tonsils? Do they have any issues with dentition? Is their jaw sitting more forward? Do they have a major overbite? I'm also looking and checking for any chances of cleft palate, cleft lip. Some children, they come to us first and we start noticing a submucous palate, and then we can help them find, get those referrals to craniofacial. And then I'm also looking at range of motion. How wide can their jaw go? Can they retract their lips? Can they protrude their lips? Same with the tongue. Can they move that tongue side to side? And can they move it side to side well? I get kids that, yes, they can move their tongue side to side or lateralize it, but they can't get it all the way over to lick the side of their lips. So I'm truly looking for that full range. And then, of course, strength. Checking that mandible strength for them. Seeing, I might give a little downward pressure to see if they can push against it. Same with the lips. Can they pucker it really nicely, or does it look weak? And so I'm looking at basically all the areas of the mouth. I'm looking from the lips, the tongue, the mandible, and the cheeks. Those are the biggest areas. And then if I can get into those hard and soft palates at the top of the mouth, and then if I can really take a look towards the back by the tonsils and adenoids, I will. Some kids are really hesitant to really let me look that far back. Another tool that I use is having them sit in the parent's lap and have face-to-face with the parent, and then having the parent lean them back and kind of making it a tickle game and fun, because when they laugh, I can see more into their mouth. And then we've got the bedside evaluation, which is what most people think of when we do a feeding evaluation, where we're sitting there watching them eat. I'm looking at 4 areas while I am watching them eat. It's medical, and we will go through these more specifically in a few slides here. Medical needs, nutritional, skills, so that's more like the chewing area, bottle feeding, cup drinking, and psychosocial. When it comes to psychosocial areas, I'm also watching during that evaluation how the parent is interacting with the child, their verbiage, how they offer things, are they child-led? And so then that's something I can build upon too in my sessions. Then some diagnoses that we're looking at providing these families are dysphagia, which you can have oral dysphagia, which is more of like your chewing kids or not transitioning to a cup. Pharyngeal dysphagia, which are more of our kids who may be aspirating. PFD, which is pediatric feeding disorder, which we're going to dive more into that in a future slide. And then ARFID, which is avoidant restrictive feeding. There are 3 different classes under those. I will say that I don't usually put ARFID as a diagnosis on my reports. Most of the time in our hospital, it is a psychologist who provides that. It does not mean that I don't treat it. I treat it to the best under my scope, but most of the time that diagnosis is coming from a psychologist. There are other SLPs who do give that diagnosis. We just don't do it at our practice. And then at the end of this evaluation, I'm trying to give them recommendations, not just therapy, not just external referrals if needed, or swallow studies. I'm also giving them one thing to try at home. And then also thinking about the different settings. If I have a kid who was completely shy the entire evaluation or started bawling because they came into my session and thought I was a doctor's office and they were going to get a shot, we do talk about maybe some other settings like home health or another outpatient facility. And then, of course, giving families some support by making sure that we're addressing what they want to work on, talking through the goals that I may be thinking of in that moment so that everything is focused on the family. That's a lot of information. I get 1 hour to do that. So to give you an idea, like, you kind of have to go through these as like your check mark box when you're doing these evaluations. If you get such a short amount of time like I do, even shorter if a family is running late due to traffic. Let's look at some assessments. Okay, so these are all found on the Feeding Flock website, all for all different ages. You can kind of see, I think the oldest one does go up to 18 years. I use most often the early feeding skills, the Neo-Eat, the PD-Eat, and the Chomps. Those are ones I probably use the most often. I will say the PD-Eat and the Chomps are probably most out of those 4. So they are not standardized, but they give you more information and you can report like a percentage, like 10th percentile, 5th to 10th percentile. So it at least gives numbers. So any of you who may be working with insurance, we have found that this has been a big help for getting approval and marking progress for those insurance plans that are just so number-based instead of quality-based. We have found these have been a really big help. So if you are needing that for your evaluations because of the insurance plans you work with, we have found this has been really helpful. Okay, pediatric feeding disorder. I tried to put everything on the slide here so then you have this as a reference. Feeding Matters also has a really, really nice handout that dives more specifically into pediatric feeding disorders. Really, it's just an impaired oral intake that's not age appropriate. And so those areas you heard me mention earlier are the associations with this feeding disorder of medical, nutritional, feeding skills, and psychosocial. You can have one, you can have all of them, you can have 2 of them. And so the medical one is, we're looking at like those, a lot of the things our physicians help us with, those cardiorespiratory compromised patients, aspiration or recurring aspiration, pneumonia patients. They might have labored breathing when they're with and without feeding. They may have color changes while they're feeding. They may sound wet or gurgly. Or they might have frequent vomiting. They might have suspected food allergies. The other one that I found was helpful with using this disorder was they never seem hungry. I get so many families that they bring their kid to me and they say, they never really give me a hunger cue. And they're older, say 2, 3 years old, and they never ask for a snack. That's a big indicator for me that we might need a referral to another specialist. The other one is nutritional. So these are kids who might not be eating enough volume to meet their weight and to have a consistent growth curve. They might be lacking a specific nutrient. Maybe they don't have, they don't have enough iron, enough protein or fats in their diet. And so that's resulting in them losing weight or showing some other nutritional deficiencies, like maybe not great hair growth or something like that. These are also kids who might have frequent constipation because they're only eating foods that don't have fiber in them. I've got a lot of kids that parents come in and they basically describe all foods that are beige. And so a lot of those foods didn't have fiber. And so now the kids are constantly constipated. And so they're always uncomfortable. And who wants to eat when you're uncomfortable? And then the nutritional criteria also addresses our kids who have limited variety. Maybe they're only eating like 5 foods, like McDonald's French fries, maybe some chicken nuggets in there, of course. You always got to have the chicken nuggets, and then some crackers in there. And they maybe only have these 5 foods, and then they only eat that all day long, every single day. And then maybe one day they finally drop one and say, nope, I don't want fries anymore. And so now they're down to 4 foods. Those are kids that we really want to address and that fall under this pediatric feeding disorder. And then we also have feeding skills, which is most of the time when I get a referral, that's the thought that they have coming in, is that there is some sort of visual skill that's missing. So that might be like they're not chewing well enough, they're having a really long meal time, like over 30 minutes. We want kids to have no longer than 30-minute meals, ideally. If they're eating like that whole time, what may happen is they ultimately will burn more energy than what they're taking in. And so that's why we try to encourage families to shorten those meals if possible, and work with them too on why is this lasting longer? Is it a chewing deficit? Is it distraction? Is it attention to the meal? Are they interested in eating? And so when they start going over that time, it's really an indicator for a longer discussion. And then under pediatric feeding disorder, there are going to be 2 classifications. Acute means it's been happening for less than 3 months. Most of the time, these are the babies I work with, or maybe someone who has experienced a traumatic brain injury. They haven't had it for a long time. And then chronic is going to be longer than 3 months. Allison, do we have any questions at this point before I dive into development milestones?
Let's just see if anybody pops anything in. We don't have anything in there just now.
Checking. I kind of gleaned over everything here at the beginning, but I want to make sure we have time.
For sure. It looks like we're good to go.
Okay, fantastic. Okay, so today I'm going to mainly be looking at birth to about 3 years old. At that point, when they hit 3, they should have most of the skills we're looking for. And then, of course, as they get older, like the amount they should be eating and the focus on nutrients kind of changes too. But I wanted to make sure we kind of hit those oral motor skills, needs for referrals, those kind of things today. I'm starting off birth to 1 year. Usually what I tell people is if you're interested in specifically like the birth to 6 months range, is to get specific education in this age group, because there's so many things you might be looking at, and it's so heavy on that family-centered care piece that I find that you really need to get that specific education in this area to treat this population well. So we're going to look a little bit at development first, because you got to know the development before you can know, is there an issue? Okay, so for the 0 to 3 months, they're readily latching to that nipple. And a lot of it is reflexive feeding at this point. They've got their reflexes like the swallow, the phasic bite, the traverse tongue. They're looking for that nipple. They're leaning toward turning their head toward it at this point. The sucking should happen automatically, and we up until about 1.5 to 3 months, everything is very reflexive. That volitional sucking starts to happen 1.5 to 3 months. And then 4 to 6 months is when we start that puree introduction. So up until this point, they have been either breastfed, bottle fed with express breast milk, or formula fed. When we start getting closer to that 4 to 6 months, what we're looking for is, can they sit more independently on their own? Can they sit more upright? Is what most people's standards are looking for to start purees. They should also be opening their mouth readily for the spoon. And most of their nutrition comes from express breast milk, formula, and purees. One thing to remember with the infant age group is food is fun until 1. So everything is for exploration, texture introduction, but it's not their primary source of nutrition. Also, in 4 to 6 months, all of those reflexes that I talked about earlier should start integrating, and we shouldn't really be seeing it as much. So let's talk about a little bit about when you see something wrong, what do you do? So I put kind of the biggest ones that I see commonly in my practice. So one of the ones that comes in that is one of my big indicators of something wrong is coughing with feeds, poor weight gain. They come in, their growth curve is the downside of a mountain. They're coughing a lot. Feeding just doesn't look pleasant for this baby. What are we going to do? Lots of choices here. Nipple changing. So every nipple, if you go walk down that baby aisle at any store and just look at the bottles, they're all different. Nipples can be different shapes, widths, lengths, flows. Britt Pados has a published article of the different flow rates that they tested to actually compare different brands and flows. And if you're going to work with this population, I really encourage you to look at that chart, because an Avent slow might look different from a Parent's Choice slow, or a Dr. Brown's 2 is going to look different from a MAM 2. And so that chart is really helpful if you have a family that comes in and that baby just needs either a wider nipple to latch onto, or they need a different flow rate. That kind of gives you kind of a good comparison chart to look at. The other choice is position changes. So if they are coughing with the feed because mom's flow rate, so if they're breastfed babies, if mom's flow rate is fast, we try changing the position that mom is in. So one option is if the flow is very fast, is having mom actually lay back. So that flow and gravity helps that flow slow down a little bit for baby. So then the milk is not as overwhelming for them. We can also change the position of baby for bottle feeding and breastfeeding. So you can put them in sideline, which actually helps everything slow down and helps baby be more organized. And then sometimes we'll even trial thickening in therapy and just see if that makes things better if we've tried everything else. And then if we need to, we'll go to that S of S, which is also swallow function study, also known as MBSS or VFSS. Goes by a million names. I apologize for that. But when we're thinking about thickening, one thing I do want to note is that there are only so many thickening agents recommended for under 12 months. The two biggest ones that we use are baby oatmeal and gel mix. The oatmeal that we like is the brand Earth's Best. We just find that it thickens the best and doesn't get as clogged. And then another common one I get is bottle aversion. Baby is formula fed or express breast milk. Mom is going back to work. Baby wants nothing to do with the bottle. Cries, turns away, no interest. Sometimes we just try a different nipple shape. But sometimes we have to ask more questions, such as like, what's going on in the environment? Does baby have a history of reflux that needs to be addressed first? So that is more indicator for me to dive into those questions. Sometimes it's, can we feed for a little bit with this nipple? Do we need to change the flow rate? Trying different positions for that baby, and then inching our way into the position that we prefer them in. But the biggest thing is that we got to get this baby fed and happy, because the biggest thing for me is to make sure baby is happy, which usually results in parents being happy. Very child-led here. A big phrase is responsive feeding, which is an entire course on its own, that if you really enjoy working with babies, I really recommend a responsive feeding course. All right, some other areas. They're gagging, they're refusing purees. I get this, and sometimes it's the normal response. So someone put something new into your mouth and you didn't know what it was and you've never experienced it before, you may gag at first, or you may refuse it at first, or you might make a face at first. And so sometimes it is those normal responses that I'm coaching families through on what that looks like, and to know that if it's only happening at the beginning or with a new flavor, it's normal and it's okay. Other things, food play is great. Even babies can do it with their little toys. I might put the food on the little toy so when they do bring it to their mouth, they get that little bit of taste. And then trying different utensils, different vessels to see if that might be a big help for them, just to have something different in their mouth. And then poor spoon feeding. Apologize, guys, it's the end of the day. So poor spoon feeding. So I might get a child who they're just not closing their lips or really their jaw on a spoon. And so some things I might try is trying like a very, very flat spoon. Even I've had some families bring popsicle sticks, like those wider tongue depressor ones. So that the child doesn't need to put their lips into the bowl of a spoon. So it's nice and flat, kind of sets up with like your smile line, and they can try to close on it. And then if they need even more help, I might even present that spoon sideways to give them even more surface area to close on. And a little disclaimer today, these are just a few things you can try when you see these issues in your evaluations or in your treatment sessions. There are so many techniques for so many different issues, but I just wanted to give y'all some things that you could take home with you today. All right, next age group, we've got 6 months to 1 year. This is where chewing starts to really start happening. We've got the munch pattern, which is that tongue and that jaw are not separated, and they're just kind of going nom, 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 nom. Their tongue does start to move side to side. We start to see that happening a little bit more. And this is when we can start introducing cups. When I tell this to families, that usually surprises them that I say, hey, it's time to start introducing a little open cup just to give them some experience. It's of course not going to be their primary way of nutrition, but it is a good time to introduce those early skills. And they're getting most of their nutrition from expressed breast milk or formula. We're even able to start introducing water. Most of our physicians say don't offer it under 6 months. Some say you can offer it 6 months and up. I've got other physicians who may say 10 months and up. So it just kind of depends on the child's primary care specialist doctor and what they recommend. And of course, if they have any other complexities, we're having to consider that as well. And then now we're also introducing some baby food with lumps. If you go down that aisle, you're kind of looking at those stages of purees. So stage 1, stage 2, stage 3. I would say like this baby food with lumps, we're kind of leaning towards that 3 a little bit. And then we've got some soft solids. And so those are the foods that you can easily squish between 2 fingers. Nine to 12 months, we're getting into vertical chewing. So this is when the tongue and the jaw start to separate. They're taking small bites of food. So those little front bites are maybe onto the side of their teeth to rip off a little piece of food, like from a muffin or a piece of avocado. And they're also starting to close their lips more when they're swallowing. So you're not getting as much falling out of their mouth, a little more bolus control. Now, of course, they're readily opening their mouth for the spoon. And at this point, their main nutrition is coming from soft bite-sized food, expressed breast milk, formula, and water. Also, during this time period of 6 months to 1 year, we're also starting to wean from the pacifier if the child is using one. So one thing that I might start to see in my clinic for this age group is they're not munching. They only want purees. We're not getting really any jaw movement. And so one of the things we like to do that's pretty easy to start implementing at home is doing something called a hard munchable, which are foods that are so hard that the child cannot bite a piece off of it. A really popular one is carrot sticks. Other choices might be jicama sticks, celery. I have some families that have done like frozen waffles, bell pepper strips. frozen pancakes. I had one family that did a super dried out licorice that they had, and the kid loved it. And so giving those to kids, like they can put it to the side, they have control of it. And so then that might get them interested in moving their jaw a little bit more. I may even like hand over hand or even present it to them, and then give light downward pressure, that little tactile cue, to see if I can get that jaw to go down and see if they'll naturally bring it back up. Another option are silicone teethers. There's also like mesh feeders. Those are the ones that kind of look like a giant pacifier, and you can put food inside of them. Those are also a great chance to not only see if we can get some more munching, but also for flavor exploration in a safe activity. Cup transitioning is also another big one that I see come in, is we're stuck on the bottle. And I get it, new things are hard. Who wants to do new things? So one thing that I tell families, one of the first things you can do is take your spoon, like an adult spoon, and present it to them like sideways or a little to the front, and make a slurping sound and see if they naturally just want to slurp and imitate you. And then of course there's Mr. Honey Bear, tried and true to all feeding therapy. If you're not familiar with the honey bear, it looks just like the bear that honey used to come in, and it has a little hole with a nice little clear straw usually. And what's nice about it is that you can squeeze his belly and the liquid will actually come up the straw. So it's an assisted straw drinking. And so then you can squeeze it, get it kind of pre-filled, offer it to the child. When they wrap their lips around it, you give it a little squeeze to kind of create that relationship of I close my lips, liquid comes out. And then over time, less and less support is needed by squeezing that belly. You won't need to do it as much for most of our kids. Using small cups for little mouths are also great too. I use a lot of medicine cups in my sessions to get kids going to kind of take sips. A nosy cup is great too. If you're not familiar with the nosy cup, it is a cup that has basically a little U shape cut out of the top so their nose fits in it. That way they don't need to tip their head back as much to get the liquid out. And then another one is plugging some straws. So you take your little straw in your cup, you put your index finger over the top, you present it to the kid. And so that's a good way, like if your family you're working with eats out a lot, that's a good way to kind of just integrate some practice into their daily lives. All right, 1 to 2 years old. So 12 to 18 months, we're really at the point now where mentally we're helping the children learn their hunger cues, like knowing that when they are hungry and they're giving us those hunger cries that we have learned up till this point, and really helping them feel like, oh yeah, you're hungry. Let's get a snack. It's time to eat. And really teaching them that really early on sets them up for success later. And so at this point, we're looking to work on drinking from a straw, a cup, or a sippy cup. We're looking for now diagonal chewing, and they're moving that food from side to side. So diagonal chewing is going to look like an X when you're looking at the child chewing. So the food should be moving in basically an X movement. The jaw is moving across, and then midline to move that food. So it's a lot of jaw movement happening at this point. And then now we're doing a lot of mixed food consistencies. We've introduced some whole milk, and of course, still having some express breast milk and water. It's really important to really encourage families to offer a variety of foods, a variety of flavors, and the foods that they are eating. Really from the beginning of them introducing solids, but really at this age, because the kids are eating more foods that the family can eat. And so really making sure families just give the kids just a couple tries of the new flavor and really encouraging that exploration so that they are very explorative eaters as they're continuing their chewing development. There was a course that I went to that said that you need 21 exposures before you can truly decide if you like something or not. And that's not 21 times of tasting something, that's 21 exposures. So seeing it, smelling it, tasting it. Okay, 18 to 24 months, we're inching into that toddler stage. Here, now we've got the rotary chew, which is kind of the last part of chewing development. When you look at a child from the front, it should look like a circle. So a rotary or circular chew. Their jaw lines will match up, the jaw slides across, jawline match up, jaw slide across. So a lot more movement, a lot more eloquent. So they're using, this is really that chewing refinement stage. So they're really able to do most foods at this point. Of course, we're chopping things up still a little bit for toddlers because toddlers are toddlers. They're in that refinement stage. They're also, I want to do everything on my own, but I'm still learning. And then they're also chewing on both sides of their mouth now instead of just favoring one side. So they should be basically using their entire mouth now for the mealtime. They're eating foods now that need quite a bit more chewing. They're still doing express breast milk. They're still doing whole milk. They're still doing water. Some major things that I see with this age group is they're just not moving that bolus from side to side. They're taking that food in. They might be mashing it with their tongue instead of moving it to the side. They might be spitting it out. They might be trying to swallow it whole. And so we might do some oral mech exercises just to kind of get that tongue moving and more aware to the bolus. And so I might do that with different forms of stimulation. Flavor is a big one. So taking something really flavorful, presenting it to the side and seeing if that tongue will follow it. Or using a Z-Vibe or a Sensi with a nice narrow tip on it. Also putting that to the side to see if that tongue will follow it, just to kind of get that motor pattern going for this mealtime. And then, of course, we want to get food involved as soon as possible. So placing that food laterally. So what I mean by that is like presenting it to the side towards the cheek pocket. So then it takes out that piece of them having to move their tongue to the side just yet. But if we put it to the side and they start chewing it, that tongue should follow that flavor. And sometimes we'll get it on that tongue and they will try to keep it over there. And then over time, we start to present things to the middle and they move it over to the side. Now, for specifically looking at chewing, such as they've got a weak chew. So what that might look like is they prefer purees or they prefer really, really soft or mashed foods, or they're not advancing to chewing meats. I had an example today, came in, child could do really soft foods really well, but if they tried to do any meats, even a chicken nugget, he would chew it maybe 2 times and then try to swallow it. And so that was kind of telling me something needed to be looked at closely with his chew. After we watched him a little bit longer, found that there was just some weakness with chewing endurance. And so we would find foods that they can practice with. So foods that are chewier that we only see as a practice food, but not as their primary source of nutrition. Another common one I'll see a lot of clinicians do would be chewy tubes. There's different levels of chewy tubes based on their resistance, and most of them are hollow in the middle, so you can actually put food in there so that when they do chew it, it's actually chewing the food, and it's like a little reward. And then in the meantime, doing some diet modifications just to make sure they're safe. And so what that means is they may need their food chopped up a little bit more. We might need to avoid certain foods just so then we've got them at a safe diet while we're advancing their skill. Another common one I get is low intake. And so usually when I see that on a referral, I need to dig more. Is it low intake because of sensory, behavioral? Is it low intake because we have recurring reflux and it's just not comfortable to eat right now? Usually what I look for in the chart is, has a dietitian seen them? Has their diet been looked at to make sure they're meeting all of their nutritional needs? And is a supplemental drink needed? And so some of the strategies I might use are like oral sensory progressions, such as SOS from K2Me. Also maybe some behavior-based, like first then, doing a couple bites and then doing a favorite bite or a preferred bite. And so some kids respond really well to that. I'm always mindful when it comes to behavior-based strategies to make sure that the child I'm working with is not masking something in order to please an adult. So that's, if you're going to use any behavior-based strategies, I really encourage you to really think about your patient and make sure that they are doing it for them and that they are encouraged and feel empowered whenever you are utilizing those strategies. And then another one, limited variety, such as some of our children who may be on more of a beige diet. And those are really similar too. We're looking at those SOS, those oral sensory progression, and those behavior-based strategies. And when I'm working with this population, I want to take a food journal of what they're already eating and how much of those things they're eating. So then I can get an idea of what maybe is our next food to try. And I'm always thinking of, I can make a list of all the foods that they're not eating right now, but if family is not eating it, if that's not part of the family's diet, I'm not going to target that. I'm going to target the things the family eats, the family is offering that might be similar to what they're already offering. So I'm thinking of flavor profile. Do they like sweet, salty, spicy? I'm looking at texture. Do they like dry? Do they like wet? Can they tolerate mixed textures? I'm also looking at like, how do they respond when food is placed in front of them? Are they bothered by the smell? Are they bothered by the presence of it? And really addressing things from the foundation of, can you tolerate a new food being in front of you? Can you tolerate licking a food? Do you understand if I asked you to lick a food, bite a food, like those choices? So I'm thinking of so many things specifically with this population. Okay, so 2 to 3 years old. Here we should be, all of our chewing should be basically refined. They should be able to eat most foods with a little bit of modification. They should be able to drink without spilling now. They should be able to chew without coughing or gagging. They should accept a variety of textures. And then of course, we're gonna still cut up challenging foods. And at this point, they can still be doing express breast milk. Some physicians will recommend a low-fat milk at this age, and then water. So one thing that I see with this age is a big texture preference. A little disclaimer, when they're 18 months to about 3 years, any of you who have children probably have experienced this, is they will go through a natural picky eating stage. That is part of their brain development. My biggest thing is I want to make sure that they still stay on their growth curve. When they start moving off of it, such as losing weight, that's when I see a need for me to step in. So really similar, that texture preference to the low intake, limited variety kiddos. We're making sure we're collaborating with a dietitian to make sure all of their nutrition is met. And of course, considering your other specialties as well, and then oral sensory progression and behavior-based strategies. At this age, sometimes utilizing that first you do a bite, then we can get the sticker, first we can do this, then we can get a toy. But like I said earlier, being really mindful to make sure that those skills are going to carry over without having to use those strategies anymore, and then making sure that that child still feels like they have control of the session. Milk preference. I get a lot of kids that will come in who are drinking 40, 60 ounces of milk and not eating a lot. And so for those kids, similar things that you see listed on the screen, but I'm also looking at asking the families, what happens if they ask for milk and it's not an option? looking at taking down 1 bottle or 1 cup every 2 weeks or a week at a time, given the dietitian's recommendations. Some of the kids I work with, we're going to do it on a 2-week based period. I may take 1 bottle away or 1 cup away, that 16 ounces, and watch their weight really closely. That's the biggest thing. We just want to make sure that that weight is staying nice on that growth curve. And then we'll see like what kind of things does family want to offer, and showing them this is your choice right now. Milk is not available at this moment, but we can have it later, and really start to take that milk down and trying to see if we can increase those solids little by little. Other one, frequent respiratory illnesses. This really is basically for any age group or any change in medical status. Is if they start getting frequent respiratory illnesses like aspiration pneumonia, sometimes even bronchitis can present that way. We need to consider, was it from getting it shared from another child or another person, or is it due to something such as aspiration? And in those cases, we're looking at thickening, we're looking at getting that swallow study done. Some patients may also benefit from NMES, which is neuromuscular electrostimulation. There are multiple brands that do NMES, such as VitalStim, AmpCare, Guardian. All of those have specific trainings that you have to attend in order to implement it. Some facilities will implement it a little more frequently. The place I'm currently at, we expect like limited progress between 2 swallow studies. Say they continue to need moderately thick based on 2 studies, and other avenues have already been addressed, like ENT and GI. Then we might consider neuromuscular electrostimulation to see if we can improve that swallow strength and timing. And then if they need thickened liquids, they come to you, they're on thickened liquids. Some options is to potentially do a systematic weaning program. And so what that means is we slowly take the thickening recipes smaller and smaller, so they're not as thickened liquids, while watching very carefully to make sure they have no change in respiratory status, no overt signs of aspiration, such as coughing, congestion, watery eyes. So when we do that program, I like to work closely with a physician to let them know, hey, we're doing this program right now. Here's what we're watching for. Of course, the NMES can be an option. And then the biggest thing is we just want to make sure they're healthy from a respiratory standpoint. So that's the goal. If they're on thickened liquids and not stable, our goal is to try to get them stable. So collaboration, I kind of wanted to go briefly through this. It's so big when it especially comes to feeding therapy to collaborate with other specialties, because there could just be so many other things going on that we're not able to see. One big specialist that I will work closely with is ENT. So otolaryngology, they are a big help with scoping and seeing if there's any structural abnormalities during a swallow. They also are a big help for any of our kids who might have tethered oral tissue, such as a lip tie or a tongue tie, that could be impacting feeding. Most of the time, they will refer to us to see is an impacting function, such as latching to the breast, successfully bottle feeding, getting that tongue lateralization, that tongue elevation, before they will go in and do any revision. When it comes to airway stuff, they're looking for anything like a laryngeal cleft, tracheomalacia, laryngomalacia. They're looking for all of those things that might be impacting the swallow as well. And then working with a dietitian, you've heard me mention it multiple times. I work so closely with the dietitians. I'm really grateful for them to help see what exactly we're looking for volume, what kind of variety for nutrients are we looking for. And then they're a big help for supplemental nutrition. So do we need to change the formula? Do we need to introduce a different supplement? And they're great at looking at what the child needs, and then also giving us a heads up, because if you need to thicken any of these formulas, some formulas thicken differently than others, and that includes breast milk as well. So if you've got a child that comes in, they're on formula, any type of supplement or nutrition really, and they need thickening, I always say try it in your session first before sending it home to the family, because anything that has a pea protein, for example, is going to thicken very quickly and with very little amount of thickener. It to the point of almost looking like cake batter for some of the brands. So that's something you kind of get to be a chemist for during your sessions. And then, of course, working with GI about feeding tubes, reflux management are probably the two biggest things I work with them on. I'll work hand in hand with a dietitian and GI if we're looking to wean a child from tube feeds. When it comes to tube feeds, there are probably the three biggest ones that you may run across are NG tubes, which are through the nose, G tubes, which just goes directly into the belly, and then the GJ tubes, which go a little further down into the intestinal system. So most of the time we need to know what the feeding schedule is, what rate they're getting through that tube. Are they continuous or bolus fed? So those are probably the questions you need to ask if you have a patient come in that has a G tube or any tube. Rate, formula, bolus versus continuous feed. How much are they getting at a time, to kind of get a feel of, is this a kid that we may need to ask the doctor, can we pause the feed a little bit to kind of increase that hunger sensation? And so those are some questions at your initial intake you may need to ask when you interact with that population. Some other teams that you may need to collaborate with might be like complex care is part of our hospital, and these are for kids who have multiple needs across multiple areas. Example, patient I had is trach dependent, G-tube dependent, wheelchair bound, non-speaking individual who has multiple neurological diagnoses and brain malformation. So they are followed by a separate team to help manage any other needs they may have that is in accordance with also their primary care doctor. And then palliative care is also a good one to work with, because you're really looking at the quality of life of the patient, not just, okay, this is what I'm looking for development-wise, but let's look at the big picture. Child may be aspirating every single consistency, but they love eating. Those are those hard questions and those hard conversations that we work closely with the palliative care to see what the family's goals are. Is continue feeding this child with some modification or going completely nothing per oral and PO. And of course, the biggest collaborator are going to be the families that you're working with from the get-go. You want to know what their goals are. You want to have that conversation of what is a reasonable goal, and really talking through what you're seeing as a prognosis and what example goals you might be thinking of to make sure that the family has buy-in. Every single week, the parents are in my session, and when I do something, I then pass it off to them to have them do the same thing. So then I can talk them through it, talk them through the anatomy, the physiology, the reasons why we're doing things, so they fully understand with what we're doing. And in the event they need to go see another specialist, they're able to say exactly what we're working on and why we're working on it. Before I move on to swallow studies, Allison, any questions yet in the chat?
Yeah, we actually have a few here, so maybe
okay,
we can tackle some.
Let's do that.
All right, so the first question coming up is, how are you adjusting the introduction of different food types for children with gross motor delays?
Okay, so I really lean on my PTs and OTs that I work with to make sure that we get them first in a stable seating position. And so that might look like different seating arrangements, some towel rolls. If they are not sitting upright yet on their own, and PT and OT and I've collaborated, I might also go ahead and talk to the physician too to see, hey, is this a kid you want to hold off for like 1 or 2 months until they've got more core stability before we start introducing foods? And most of the physicians say, like, go ahead and introduce it in therapy first and let's see how it goes. Especially because we've got everyone in-house at my clinic. I have previously worked home health, so then I've had physicians take a little more hesitancy about it, about like, hey, can we see if OT and PT can work on the core for a few more weeks just to see if we can get them in a better seated arrangement for them. That's for the first introduction of it. When it comes to solids, like things that they do need to chew, the biggest thing really is making sure that we can get that head and neck alignment. So then they are able to eat, like such as using a harness. I'm thinking of specifically some past patients I have had that are cerebral palsy that the likelihood of them being able to completely sit upright and sustain that for a meal, there's not high likelihood for that. So in those events, we do lean on our equipment specialists, our ATPs and things like that, and PTs and OTs to kind of guide us in that seating arrangement.
All right, next question. I'm a school-based therapist. Do you commonly see OTs or SLPs or collaboration between the two disciplines primarily taking feeding kids?
I'm sorry, say that again, Allison. I couldn't hear all of
it. So I'm a school-based therapist. Do you commonly see OTs or SLPs or collaboration between the two disciplines primarily taking feeding kids?
So under the age of 3, I see it about 50-50 OT and SLP. A lot of the early childhood intervention, at least in my area, it's split between who addresses it. It might lean a heavier on the SLPs, but I've seen a lot of OTs as well. As well as in the NICU-based areas, I see OTs and SLPs both in those settings. Now, above the age of 3, the way our program is divided is speech will kind of target that swallow dysfunction, oral motor skill area, and then any of the infants with volume and things like that. And then our OTs kind of take those sensory behavioral based feeding kiddos.
Very good. All right. You mentioned that being a picky eater is a part of growth development. Can you elaborate?
Yes. So there's a difference between a picky and a problem eater. Kids, like I said, that kind of starts around 18 months. They go through a natural picking development stage, but it should never go below 15 foods. Really not below 10 different foods. And if they start getting like really, really brand specific too, that's another indicator of being more of a problem eater. So I'd say the biggest differentiation between the two is the number of foods they have and how they respond to new foods being presented to them. Even if it's just sitting on their plate. A lot of my problem eaters, like they see the food on the plate and I'm getting tears, I'm getting fight or flight response.
All right. For an older child who is a picky eater and completing therapy, how many new foods would be typical to eat and swallow in a month?
Oh, that one's tough because that can be very kid dependent. I think if you've got a kid that came in and they were really, really restricted to, say, 6 foods, it really needs to depend on where they start for each food. That one's a hard one to answer because it really depends on the kid's response to any new food placed in front of them. If they're at the stage where, hey, I will bring it to my mouth and I will lick it, I can maybe get those kids to willingly, I'm not saying they're going to eat like 2 ounces at a time, but willingly try that food. I don't know, maybe 2 to 4 foods that month. And then I've got some kids that because they have a better understanding, say they're like 10 or 11 years old, they've got a better understanding of what's going on with their body. We can expand 5, 6 foods in a month, depending on how often and how much they're presented to them. But then I've got my littles, my 2-year-olds that sometimes in my 6-month period of seeing them, I may get 4 foods successfully eaten. But it really just depends on the kid.
All right. So I'm an OT working in schools. I have a 5-year-old girl with a 5-year-old with a diagnosis of Noonan syndrome. He brings a supplemental drink to school in a bottle, which makes him stand out when in the cafeteria with his peers. He's unable to drink from a straw and refuses to try a sippy cup. Any suggestions for helping him progress to a cup?
I really love that there are some school-based therapists here. I really appreciate y'all. I work with y'all also on a day-to-day basis, so I appreciate. Just wanted to put that out there. I appreciate y'all. So I guess, okay, so you mentioned straw is really hard. He's not a fan of sippy cups. I would look at the brand bottle that he's drinking from, because if it's like a Dr. Brown's, they have like a, you'll still like use the bottle, but the tip is different. And it can be like a soft sippy cup. That might be an option for him. It will initially stand out, and you can get some with handles, but that might be like one way to transition. If he's not wanting to do the sippy cup, you could transition to that and then try to introduce a sippy cup again. It's kind of where my brain went first on that one. But for that one, I really encourage you to reach out to me by email, and we can chat more specifically about that kid.
Great. And then the last one that's in here for right now is what approach to use with children with autism who are very selective eaters?
So those are, I will use like oral sensory progression and some behavior-based strategies with them. And that's why I mentioned earlier being really mindful when you're using behavior-based strategies, because and I say this from observing it in a variety of settings, is the take a bite, take a bite, take a bite. And then you get your reinforcer, or you get a token on your token chart. It yields results, but I always want to be careful with that to make sure that kid is not starting to mask. I will sometimes get kids who come in who are 9, 10 years old, autism, they've done those type of therapies, it did yield results. And then they come in and I'm asking them to just try something. And the look on their face is, I'm going to do it, but I'm not happy about it. Like my body looks uncomfortable. And so then we're talking through listening to your body. How is your body responding to that? So the short answer is oral sensory progression, name brand SOS, and just some general behavior strategies first, then token charts, talking about preferred foods, being a food detective, like talking about the texture, the color, the taste in our mouth, and then just always being mindful as you're implementing these type of strategies.
Awesome. Well, that clears out the question box for now, so we can move on.
Awesome. Okay, great questions. So I wanted to jump into swallow function studies, MBSSs, VFSSs. Like I said, I'm sorry that there's a million names for it, but you will see all of those across different settings. My facility uses FSS. So just wanted to share a little bit about it, because you may be the first person that sees a kid that may need this. And so what it assesses the swallow function and safety under a video x-ray. We're taking a lateral view. We're having them drink a contrast called barium that helps us see if any of that liquid is going into the airway. So we're looking for two things. Penetration, which means it wants to go into the airway, so it might peek over. Like in this image here, this person is having a small penetration. And then aspiration, which means it does go into the airway, and when we aspirate, it can lead to aspiration pneumonia, illnesses, increased congestion, etc. We will see these kids based on mainly the main ones that qualify for getting a swallow study is if you see them and the biggest things are overt signs of aspiration, of congestion, watery eyes, coughing when feeding. Most of the time it's when liquids, but cerebral palsy, muscular dystrophy, any progressive disorder, you may see it with solids as well, especially if they're older. You've got your 15, 16-year-olds who now everything has expanded, because when you're a baby, all of your anatomy is kind of squished together. As you grow, it expands out. Everything is now expanded. Their disease is now progressing. We may start to see it with solids as well. in your infants, vomiting sometimes is a sign of aspiration. Struggling during bottle feeds, if you've tried all the things but you're still not sure what's going on, they may need a swallow study at that point. A big thing that I like to talk about with swallow studies is readiness. I will say our kids with severe oral aversion are very likely not going to participate in a new environment with a new flavor, such as barium, in their mouth. So if you have a kid, you're thinking they might need a swallow study, but they also have severe oral aversion, you can work on that readiness in therapy by seeing if they will willingly drink 1 to 2 ounces on demand for you while in a seated position. So that whenever they come see us for a swallow study, we can get them in that chair and make it a positive experience as much as we can. The barium itself, it usually only has a really, really light, sweet taste. Sometimes we can flavor it, but it is white, so that might be another piece for your oral aversion kids. If they're color-based picky eaters, we might have to get also creative to get that barium the color that they're most comfortable with. And then after we do the study, we review it, and we're really watching closely for anything that might be going in the airway, and we'll make changes during that study. So we'll usually start with a thin liquid of barium and then work our way up to half nectar or slightly thick, then nectar or mildly thick, and then honey or moderately thick. And then, of course, doing some solids as well. And we'll review it with the families and talk through everything. And what we're also considering is any of their medical diagnoses, like I mentioned earlier, like CP. We're also looking for that laryngeal cleft I mentioned that ENT will diagnose, any neurological involvement. I've got some kids who have diminutive brainstem, which we need for swallowing, and so we have to consider that as well when we're looking at these studies. I wanted to make sure y'all had some other options for continuing ed, so I just listed a few here to kind of expand your knowledge in this area. I love all of them. I've taken all of them and love them for all different reasons. So if you get a question on what's my next step, here's the population I work with, feel free to email me and we can chat through it and I can kind of give you some ideas. A lot of them also have like free resources online. Feeding Matters has some, Melanie Potic has some, Feeding Fundamentals has some too on social media that are all great resources. And then that's my email. I am happy to answer any questions about feeding. Like I said, today was really just an introduction of everything, of developmental milestones, some things that you can take with you into your practice now. But if you have a specific client that you're working with that you'd like some input on or some ideas on, I'm happy to try to give you some support. I also work with a wonderful, great team that I can also bring those harder, more complex questions to, that we can always brainstorm some ideas for you as well. That's what I have for y'all.
Awesome. So we have a couple of questions. It looks like at least one rolling in. So the first one, are any of the continuing ed recommended neurodivergent affirming? If not, do you have any other suggestions?
I don't know if any of them market as necessarily neuroaffirming. I mean, the Feeding Matters and Feeding Fundamentals, they look a lot at infants. So it's not necessarily working with like our neurodivergent population. I don't know if SOS maybe has adjusted to be more neuroaffirming, like including those terminologies. I find that SOS is more neuroaffirming than other techniques for maybe working with our neurodivergent population, but I don't think any of them specifically say we are like neuroaffirming. I wouldn't say any of them are the opposite of that though.
Okay,